Dr. Kapardhi will speak first. He will speak on is radial access the preferred route now? What is the evidence support?
Everybody, and thanks to the organizers for giving the opportunity to give this important lecture. So nowadays the radial access interventions as well as the angiograms is increasing worldwide. So the topic is radial access the preferred route now? What does evidence support? So before going to the radial route, the advantages as well as why it is preferred, we have to take the what is the important traditional route advantages like transfemoral advantages as well as disadvantages. As we know, it is a well tested as well as it can allow the bulky catheters as well as bulky devices as well as large sheaths. But the basic disadvantage is access site complications, especially including these hematomas, pseudoaneurysms, AV fistulas, and sometimes rarely thrombosis also, and sometimes the fatal complications of retroperitoneal hemorrhage. So all these are, and this will prolong the hospital stay. That is another important disadvantage. And another important is patient, it produces discomfort to the patient of prolonged immobilization of the leg, as well as sometimes local vascular occlusion devices also it can be used, but they are cost prohibitive. We are not using as a routine basis. So with this background, why this is? Because we know the femoral artery anatomy, it is a almost large sized vessel, as well as it is closely associated with this inguinal ligament and more prone for complications because of the requirement of the prolonged compression. So if you take the local access problem, what is the magnitude? It is most common complication of the coronary intervention which results from access problems. Almost over a million of coronary interventions performed a year, almost 10,000 million percutaneous procedures in 2000, it is very, very high. And this is the commonest problem out of other cardiac problems, other problems, the access problems are most common. And the complications are bleeding, sometimes major or minor bleedings. Major bleeding means requiring blood transfusion, and pseudoaneurysms, AV fistulas, retroperitoneal hematomas, and arterial occlusions as well as infections. So we all have seen this happen very oftenly, very big hematomas, especially when the manual compression is not effective, our local technician is ineffective. And we are seeing these type of complications also sometimes. There is a pseudoaneurysms which is necessitating the either conservative or peripheral vascular surgery help. And this also we have seen, especially a large retroperitoneal hematomas leading to the recurrent hypotension and sometimes going to the surgical evacuation of the hematomas. So the complications rate as per this data, hematoma is very high incidence, 0.89%, and the least one is retroperitoneal hematomas, 0.19%. And these complications, as the AV fistulas as well as arterial occlusions are very rare, less than 0.1%, the femoral roots. So how often these occur? Especially there are a lot of registries and landmark trials determining the local vascular problems. Especially the GRACE registry, it was shown that mortality is associated with a major bleeding, especially in acute coronary syndrome, both 30-day mortality as well as annual mortality. And NHLY registry data, it was also shown that access site hematoma requiring blood transfusion predicts mortality in patients undergoing percutaneous interventions. So this is a major bleeding increased 1-year mortality after angioplasty in 6,001 patients. So statistically this is significant. So access site bleeding increases mortality. The landmark is a mortal study, that is mortality benefit of reduced transfusion after angioplasty via the arm or leg. So here it was shown transcatheter interventions better than transfemoral interventions. Very significantly there is a difference in mortality. And of course, to reduce bleeding in a femoral approach, there are so many vascular closure devices approved by FDA, but we have seen commonly the St. Jude Medical, but we are using occasionally in affordable patients, AngioSeal device. And there are studies like STAND 2 study which was shown that more frequent local complications can also occur even after using hemostatic devices. And of course, current femoral closure devices need to be improved much more. And with this background, we move to transradial approach. What are the advantages? Mainly, it is a user-friendly to the patient. Mainly, patient feels more comfortable, and it reduces the hospital stay, so that the cost benefits also will patient will enjoy. Along with the local access problems will be very much minimized in transradial route. Almost it can be virtually eliminated if the operator gains the experience in transradial approach. Of course, the disadvantages are especially the anatomical variations. The failure rate may be more to cannulate the coronaries, and there is switch over to the femoral route can also occur. And second important, because it is a medium sized vessel and it won't allow the sheaths more than 8 French. And sometimes the bulkier devices, if you take for complex angioplasty, especially chronic total occlusions as well as bifurcation left main, you have to go to the femoral route because it won't allow the bulkier devices. So this is the anatomy which made the user friendly, the transradial access. There are no major nerves adjacent, and it has a dual circulations because LNS test is positive in more than 90% of the cases, indicating the adequate circulation, and there is easy compression is possible. So there is a reduction of the evidence complications of hematoma and pseudoaneurysms, and there is a tight space, so there is a less complication of the pseudoaneurysms. So there is a lot of randomized control trials, 23 randomized controls from 1980 to April 2008, until recent landmark trial of Rivals trial, which was shown that radial access reduced the major bleeding, and there was a corresponding trend in reduction of the ischemic events compared to the femoral access, even in acute coronary syndromes. And trends in the USA also increasing gradually the transradial procedures from 2007 onwards. So ultimately 2011 ACC, AHA and SCI PCI guidelines, they recommended the transradial access class 2A. The use of radial artery access can be useful to decrease the access site complications. There are a lot of published articles about transradial interventions in various journals, and bulk data is there which are published showing the superiority of transradial interventions or transfemoral approach in reducing the local or access site complications. And Koreans, they did maximum workup on more registry prospective data on transradial interventions systematically. First is the operator intervention, because in transradial interventions the operator experience is more important, because the learning curve is very steep. Once it gains the experience, almost the complication minimum, and transfer from the transradial to transfemoral also very minimal. And regarding the angiographic data, especially radial versus femoral approach for percutaneous coronary interventions in patient with acute MI, that is Radiami study, which was shown that superiority of radial approach in reducing the local site complications. Next is the vascular complications and access crossover in 10,676. This is a large prospective study of the Korean data, which was shown that concluding that radial approach is very effective as well as safe, especially the operator experience and hospital equipped with transradial intervention experienced operators. And access site preparation, of course, it varies from site to place, and there some local mixture will be there. And here standard transradial, we use the cocktail of the NTG as well as heparin and diltiazem as a to reduce the vasospasm, especially neuroleptic analgesia is very useful, giving fentanyl and midazolam combination. And then they compare the radial angiogram between the radial and femoral. The transfer to the femoral route will be more and more minimal as the operator become experienced in transradial interventions, and availability of the more and more sophisticated the hardware, especially some companies dedicatedly, Thermo company is associated with the dedicated radial hardware. And regarding the antiplatelet resistance and bleeding almost similar, but radial versus femoral access, if it compare, there is a reduction of the local site complication, even if you use liberally the antiplatelet drugs as well as the anticoagulants. And compression methods also vary, because when we start the transradial program 2004, initially we use some local compression devices, cyto device like that, with which some more complications occur, pressure necrosis of skin and all these. But nowadays with the usage of TR band, almost the local site problems and radial approach also will become minimal. And of course, catheter wide, this is very, very user friendly, especially with transradial. Even with single needle and single wire and single catheter, we can complete the procedure very easily within 10 minutes, especially which is very feasible. And nowadays with a very small vessel, radial, and where the spasm incidence is more, sheathless insertion is also very possible, which will reduce the spasm. Especially the Koreans, they developed this technology, and recently it was published in the article. With this, the comparisons with the transradial and transfemoral, even success rate is almost equally effective with the transfemoral interventions. And only thing is the major vascular side complications, it vary from almost 0.1% radial and 3.3% with the femoral approach. So this is a systematic overview of the 12 randomized studies which was shown that radial route the vascular problems are minimal and entry site bleeding complications less with transradial interventions. But major that MACE procedures almost they are similar with the transradial as well as transfemoral. Radial versus femoral approach for percutaneous coronary diagnostic and interventional procedures, systematic overview and meta-analysis randomized trials show that MACE is almost similar between two this one. But major bleeding is less with transradial interventions and success rate is similar almost. And death, myocardial infarction and accident bleeding complications are minimal with radial compared to the femoral interventions, and death, myocardial infarction, accident bleeding complications is minimal. And this is most important, which is a landmark study, that Presto acute renal syndrome trial, which was shown that non-ST elevation MI, the major determinant at 30 days as well as annual mortality is local site bleeding complications, and it related the mortality. With transient intervention is very minimal 0.7% and transfemoral it is almost 2.4%. And especially in acute coronary syndromes and with the usage of 2B3A blockers, which was shown that between femoral and radial interventions, the local site bleedings is very high, which determine the mortality. So with this, the result of meta-analysis or randomized study, which was shown that MACE rate is equal between both transradial and transfemoral interventions. The conclusions are that transradial and transfemoral approach are equivalent in terms of major safety with a similar rate of MACE, but the transradial access virtually eliminate the entry site local complications, almost nil in transradial, whereas 2.8% in transfemoral approach. However, the transradial approach is more technically demanding because the learning curve is steep. So during this, some complications may occur, but once the operator gains experience, it is almost minimal, and transfer over to the femoral also minimal, and with a global failure rate of 7% in transradial. Nonetheless, a clear ongoing trend towards the equalization of two procedures in terms of procedural success is evident throughout the years, probably due to technological improvement of material and increased operator experience. So with this background, the rival study was shown the superiority of radial access in reducing the complications, and especially in the female gender, the hematoma incidence is very high with the transradial, both grade 1, grade 2, grade 3, grade 4 hematomas are very high. And so recently published article that rifle ST elevation acute coronary syndrome. So that is radial versus femoral randomized investigations in ST elevation in acute coronary syndrome. Especially here they compared systematically between the radial and femoral interventions. The conclusion of the study is radial access in patient with ST elevation acute coronary syndrome is associated with significant clinical benefits in terms of both lower morbidity as well as cardiac mortality. That it should become the recommended approach in these patients provided adequate operator and center expertise is present. So this is recently published just 2 days back. And with this we have the experience. We started our program from May 2004 to March 2012. Total 21,000 patients underwent transradial interventions. The cocktail regimen used in our transradial intervention program is nitroglycerin 100 micrograms, diltiazem 5 micrograms, and unfractionated heparin 5,000 units heparin. So we observed complications of small hematoma during the learning curve 0.2%, small aneurysms of 0.2%, and local thrombophlebitis of 0.3%, And pressure necrosis we observed when we use the cyto device. After replacement of TR band, it was almost no more, and asymptomatic occlusions are also noticed. Dissections of radial brachial 0.3% and looping of catheters into the vascular pathway noticed in 0.1%. Severe vasospasm in spite of duct therapy causing difficult to engage coronary and transfer in 0.4% we observed. The success rate in transradial approach for percutaneous interventions in our series, we observed 98.5%. Switchover rate from radial to transfemoral is 1.5%. So, with this, casual approach is danger even for this job also. So, radial especially much more cautious, and we observe this pressure sore here in the beginning of the program, and we also observed during the hematoma especially asymptomatic perforations of the small branches when you use this thermovire. And okay, this is the TR band which almost eliminated virtually local vascular problems. And conclusion, optimization rather than a preference is especially vascular access in my view. That TR access is morely cost effective, it reduces the hospital stay, and especially you should use when their hardware is available and more experienced operators, and especially patient safety is important, and if the patient prefers, you have to do transradial access. And transfemoral access is preferred whenever the patient is hemodynamic instability where IABP is required and where venous associated right heart catheterization or temporary pacing is required, and whenever the bulkier devices we use like rotablation or thrombosuction catheters or kissing balloon techniques in complex angioplasties where requires more than 8 French when you prefer transfemoral. And especially in this case where they are amputated both legs, you have to go transradial, and it is obligatory in this type of patients. So, this is the team with this always their preferred route when the operator is experienced and hardware is available, always transradial is preferable route in my view. Okay, thank you.
Thank you, Dr. Kapardhi, for excellent presentation.